Hi class, my name is Nicole Scott. This is my video presentation for our week 9 discussion board regarding abnormal uterine bleeding. So for history of present illness, this is a 42-year-old patient, G2P2, presenting to the clinic today with complaints of painful menses with heavy bleeding with intermenstrual bleeding the last 3 months. She's currently having a bleeding episode today. No current contraception for this patient as husband had a vasectomy. So chief complaint for this patient presenting to the office for heavy, painful menses with intermenstrual bleeding. So subjective data that we would want to gather for this patient include asking questions about the type of pain she is experiencing with describing words like cramping or aching. I would want to ask if she's having any sharp pain with menses as well, how long the pain persists for, when the pain starts, if any over-the-counter pain medications like Tylenol or ibuprofen alleviate the pain at all. Some women can experience PMS symptoms like nausea, vomiting, dizziness, fatigue, headache. I'd want to ask the patient, if she's experiencing any of this as well. Amount of bleeding is extremely important for this patient, so we want to know how often she's changing her pad tampons when she is, going through menses, if she's passing any clots, along with any symptoms of anemia such as fatigue or dizziness. Thorough history should be collected for any patient coming in for abnormal uterine bleeding, including family history, sexual history, any GYN history that's applicable, social assessment, along with how the pain and bleeding is interfering with her daily activities when she does experience it. Questions about bleeding disorder should be assessed and discussed with the patient as well, such as if she's experiencing, bruising twice per month, bleeding gums, frequency of that, or any family history of any bleeding symptoms. I would also want to ask the patient about any recent weight gain or loss. This patient is 5'3" to 180 pounds, so her BMI did come out to 31, which falls under obesity. So that can be also playing a role for her abnormal uterine bleeding. We just want to touch base on that too. And then for objective data, of course, abdominal exam would be good for this patient, and then the GYN exam, including pelvic exam, definitely. Looking for any signs of tenderness, guarding upon the abdominal, along with any masses. GYN assessment, pelvic exam, looking for any signs of infection, possibility of an enlarged uterus. And then since she is having a bleeding episode today, we can kind of, assess that a little bit further as we do the pelvic exam. So labs, swabs, gonorrhea, chlamydia should be, can be collected for this patient. Urinalysis, pregnancy tests for rule out. Blood work for this patient that should be collected, CBC with platelets to determine severity of bleeding, rule out any anemia, TSH to see if she has any thyroid dysfunctions, and then coag studies and prolactin levels should be collected for this patient. So our diagnosis is menorrhagia and then dysfunctional uterine bleeding. So for planned diagnostics, imaging, ultrasound should be completed to examine any structural abnormalities that could be occurring. And then when the patient's not having a bleeding episode like she currently is, I would have her come back in, do a full well woman's exam, bleeding, pelvic, and a PAP at that time. Pharmacologic. So for dysfunctional uterine bleeding, menorrhagia, COCs and over-the-counter pain meds should be advised and talked about for this patient. Low-dose COCs are known to control excessive bleeding. Another option can be a Mirena IUD. Iron supplements may be needed, just dependent on the results of the CBC. And then, of course, before prescribing COCs, if that's what we are going to do pharmacologically for this patient, we need to rule out, no smoker, review vital signs history, current hypertension, and then ensure she doesn't have any history of DVT as well. And then non-pharmacologic, daily exercise, healthy diet, heating pad when painful menses are occurring. Those are things she can do. Diet and exercise are probably very beneficial for this patient, just considering her BMI 31.9 and her height was only 5'3", weight was 180. So diet, exercise, losing weight can, maybe play a role into her abnormal uterine bleeding and kind of balance that out. And then, of course, educating, lifestyle changes, need for proper use of medications, whichever way we go, the COCs, the Mirena, kind of educating her whichever one we pick. Of course, for COCs, make sure you're taking that every day, make sure it's working properly in that way. And then I would also want to keep or educate the patient on keeping a menstrual calendar for the next few months, for the next 3 months, and then to be discussed at her follow-up appointment. I would want her to include symptoms like bleeding, pain, emotions, how she's feeling, how often she's changing pads, tampons. All of that should be included in this journal so that we can review this in 3 months. Referral may be needing to be seen further by an OBGYN provider for further treatment if the bleeding is not controlled solely by either COCs or possibly Mirena IUD. The patient, should be educated, should be made aware that there's other treatment options available. This isn't the only thing that we have, for menorrhagia. Treatments, if we move on to those, will be invasive, such as an endometrial ablation, but she should know that there's other treatments that, we can move on to if this doesn't work, what we're doing first. And then I want to see the patient back in 3 months to discuss cycles, medications, any pain that she's having, with menses. And then, like I mentioned earlier, at that time, I'd like to complete a well woman's exam, get a PAP at that time, and just kind of rule out more of that. But that is my workup for this patient. Thank you.